The Epilepsy Foundation is pleased to share with you an educational webinar providing an overview of pediatric epilepsy surgery. The mission of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. My name is Dr. Elaine Kiriakopoulos, and I would like to extend a warm welcome to everyone who has joined us this evening. It's wonderful to have you with us for tonight's learning. I'd like to review with you the format for tonight's webinar. Throughout the presentation, all phone lines will be muted. However, we would like to encourage everyone to submit their questions at any time during the webinar. To do so, type your questions into the question window on the GoToWebinar panel and click Send. We will read your questions aloud and address them during the question and answer portion of the webinar. Please keep your questions general in nature, as the webinar is intended for educational purposes. This webinar does not take the place of individual medical advice. The webinar will be recorded and available for viewing and listening on epilepsy.com. The Epilepsy Foundation is working to provide information and education that serves the spectrum of individuals and families impacted by epilepsy. It's common when you have a question about your health or your loved one's health, you may hear or read things that you're not sure how to interpret. The Foundation's webinar education series aims to bring together expert clinicians and scientists who can share with you the most up-to-date and accurate information to help answer your questions. We also share with you experiences from members of our epilepsy community, as peer-to-peer education provides vital learning for families facing the challenges epilepsy can sometimes bring. As most of you are aware, there are a number of treatment options which exist for children impacted by epilepsy. These treatment options include anti-seizure medications, dietary therapies, which are medically prescribed and monitored, neurostimulation, which involves the implantation of devices to stimulate the central nervous system to help control seizures, and clinical trials where new therapies are carefully and rigorously tested and developed for the treatment of epilepsy. Tonight's webinar is going to focus on epilepsy surgery and the surgical options currently available for children impacted by epilepsy, which is refractory to the other therapies. Pediatric epilepsy surgery and epilepsy surgery in general bring to light a number of considerations. Some of these include the goals of surgery, setting expectations before surgery, weighing potential risks and benefits, and why someone may or may not be considered a surgical candidate. It's also important to understand the recovery process and what we know about the impact of surgery on a child's development and quality of life outcomes after surgery. And to help us with this learning, I'm so very pleased to share with you our guest speakers. Dr. Nancy McNamara received her medical degree from the University of Michigan. She went on to complete her residency in pediatrics and child neurology at the University of Michigan. She then completed an epilepsy fellowship at the University of Michigan. She is now an assistant professor at the University of Michigan Mott Children's Hospital, where she focuses on the diagnosis and treatment of childhood epilepsy, in particular pediatric epilepsy surgery. We are also thrilled and very thankful to Dr. McNamara, as she is our pediatric epilepsy surgery editor at the Foundation on epilepsy.com. Thanks so much for being here this evening, Dr. McNamara. Megan Maddow is originally from Blue Springs, Missouri, but grew up in a small town in central Iowa. She has lived in eastern Iowa for the last 7 years. She has a background in health and human services with a special interest in the special needs population. Megan has worked for a variety of nonprofit and for-profit agencies, including the Iowa Child Advocacy Board, REM Iowa, and Iowans for Safe Access. She is passionate about helping and advocating for individuals who have been faced with special circumstances, especially in the healthcare and epilepsy world. Megan's passion for epilepsy began due to a diagnosis of intractable epilepsy for her son, resulting in a left functional hemispherectomy in 2016 and a shunt placement in early 2017. She feels her journey through the world of epilepsy would not have been as paved without the help of the Epilepsy Foundation, and she hopes to help other families who struggle through the diagnosis as well. Thanks for being here, Megan, and thanks for all you do. There are no disclosures for this evening's presentation. At this time, I will turn the webinar over to Dr. McNamara.
Thank you for that introduction. So tonight I'm going to talk to you and give you a little bit of background about the diagnosis of epilepsy, defined drug-resistant epilepsy. We'll briefly touch on different seizure types and talk about epilepsy centers and teams in the context of epilepsy surgery. We'll also talk about what is involved in the epilepsy monitoring unit. Epilepsy, for those of you who are not aware, is a chronic neurological condition characterized by the tendency to have recurrent seizures. Some children just have 1 or 2 seizures, whereas other children can have multiple seizures every single day or week. There are many different types of epilepsy, and importantly, a diagnosis of epilepsy does not indicate a cause or a prognosis. These things are very individualized and need to be discussed with the child's epileptologist. Treatment decisions in epilepsy are individualized as well. The formal definition to have an epilepsy diagnosis was always classically when a child has 2 or more unprovoked seizures in greater than a 24-hour period. However, a few years ago, this diagnosis was modified to when a child has 1 seizure plus an increased risk for seizures, typically 60% or greater, to have another recurrent seizure. This would be based on the child having certain features or abnormalities on an EEG or an MRI, or presence of other risk factors such as autism or genetic disorders. Some children have specific epilepsy syndromes that are able to be identified based on a first EEG. Classically, we treat with medications first because the vast majority of children will have their seizures controlled with medications. However, as I anticipate that many of you on this call are aware of, there's something that we discuss very frequently called refractory epilepsy or intractable epilepsy. And this is when a child or an adult has a failure of 2 well-tolerated, appropriately chosen medications, titrated up to maximum dosages, and they continue to have seizures. This is when we change gears. This is when we say, what could we be doing differently? What other treatments are available for this child or this person? There are many different seizure types, and this is an important groundwork to discuss before we move on. Seizures can be focal, meaning they come from one area of the brain. They can be generalized, coming from all over the brain at once. And sometimes we don't know, and further testing is needed. Seizures themselves, we discuss, especially if they are focal, whether or not the child or adult loses awareness. So a seizure can be focal, involving one part of the body, such as arm twitching, but the child can be aware. That would mean that they have focal seizures without loss of awareness, whereas other people may have loss of awareness with their seizures. We also discuss other features of those seizures. What does a person look like? Do they have tonic stiffening, jerking, loss of awareness? We use these terms and other terms to discuss the type of seizure that a child or adult has. Another important concept is an epilepsy center. Epilepsy centers are accredited through the National Association of Epilepsy Centers, and this accreditation helps ensure that the center meets criteria to deliver expert levels of care. Epilepsy centers can be either a level 3 or level 4, and those that are level 4 centers offer epilepsy surgery. Epilepsy centers provide both outpatient and inpatient comprehensive epilepsy care, and the specialists are experts in the diagnosis, evaluation, and treatment of epilepsy. It's important to know, especially if a child or a patient has refractory epilepsy, if they're being seen at a level 3 or level 4 epilepsy center. There is not just one person on that epilepsy team, however. There are multiple people that make up a comprehensive epilepsy team. And this includes the epileptologist, who is somebody who has undergone training to be a neurologist or pediatric neurologist, and then subsequent additional training to learn how to read EEGs and take care of patients with refractable epilepsy. Additionally, there are epilepsy nurses who have specialized training in taking care of patients during seizures, neuropsychologists who are experts on the behavior and cognition of patients with epilepsy, neurosurgeons, obviously, to provide epilepsy surgery, neuroradiologists to help interpret the multiple scans needed prior to epilepsy surgery or when in dealing with patients with refractory epilepsy, neuropsychiatrists to help with mood and behavioral disorders that commonly go along with epilepsy, EEG technologists to help perform appropriate and excellent EEGs, and social workers and case managers to help manage the many facets that go along with having intractable epilepsy, to help support the families as well. An EMU, or an epilepsy monitoring unit, is another common term that we need to define and discuss. This is typically a unit or wing in a hospital where staff is trained and the rooms are wired especially to provide continuous EEG monitoring and video monitoring for patients as they're undergoing evaluation for epilepsy surgery or for better care of their intractable epilepsy. And EMUs provide the highest level of diagnostic and treatment services for people with difficult to diagnose or to treat seizures. So who can surgery help? Surgery is not for everyone. So remember that epilepsy is more than one unprovoked seizure. And intractable epilepsy is when seizures continue after 2 appropriately chosen anti-seizure medications have failed. Epilepsy surgery in general, as we talk about the classic resective surgery, this is for when somebody has focal epilepsy, not generalized epilepsy. And most commonly focal epilepsy or focal seizures that come from a part of the brain that can be removed without injuring the child or without leaving deficits. Sometimes exceptions are made. So who should be considered for epilepsy surgery? Anyone with intractable focal epilepsy whose seizures are causing an adverse impact on their lives. One caveat to this would be patients with intractable atonic seizures. These are referred to as drop attacks or drop seizures. When a child or adult falls very quickly, this leads to significant injuries, oftentimes fractures or bleeds in the brain. And for these children, a resection is not offered, but rather a disconnection of part of the corpus callosum called a Corpus Callosotomy. The visual that you see here on the left is imaging showing somebody with focal epilepsy, and you're just seeing one part of their brain light up during a seizure. Now, here's a list of medications. We have a lot of anti-seizure medications. You can see on the x-axis here, this is the year of introduction. So we have medications since before the 1900s, so well over 100 years old, like phenobarbital, that we still very commonly use in infants. We have other medications that came around in the 1960s, like ethosuximide, that we still very commonly use, or acetazolamide, phenytoin. We have medications that came out in the 70s, like clobazam, that we very commonly use. These are referred to as the second generation medications. And then the third generation medications, many of those were discovered in the 1990s, We have a plethora of medications, but it really still doesn't matter which medication you choose. After someone has failed any two of these medications, the likelihood of them becoming seizure-free with a third medication, no matter how fancy it is still less than 10%. We have other treatment modalities, however. So we have things like the ketogenic diet. The ketogenic diet has been around since biblical times. People observed that when children or adults would fast and pray for their epilepsy, their seizures actually got a lot better. Believe it or not, that was sort of the beginning of figuring out the ketogenic diet. There was a resurgence of interest in the ketogenic diet in the early 1900s when a fitness guru got very interested into the ketogenic diet. Sort of went by the wayside in the mid-1900s when so many more anti-seizure medicines came about. And then there was again a resurgence in the 1990s, and we still very commonly use it today. Neurostimulation, believe it or not, has actually been around for a long time. So neurostimulation refers to stimulating part of the brain that's causing seizures. People have been trying to get rid of seizures in many different ways for a long time. And so electrodes were placed in multiple parts of the brain starting in the mid-1900s. There's also something called a vagus nerve stimulator, which stimulates the vagus nerve in the neck, which we'll talk about briefly at the end. That was introduced in the mid-1990s and is still actively used today. And then RNS, a type of neurostimulation called responsive neurostimulation, which was FDA approved in 2013 in adults and is most commonly being used in adults, and it is considered a palliative surgery. So with all these medications, I just showed you that close to 40, why would we ever need to consider other treatments? And this is because, as you'll see from this very excellent research, that yes, many people will become seizure-free after the first drug is introduced, about half. And then when a second seizure drug is needed, a small subset of those patients will become seizure-free. But then once you get into the third anti-seizure medication and the fourth, the likelihood of you becoming seizure-free is much lower. It doesn't mean we're going to stop trying, and it doesn't mean that hope is lost by any means. It just means that's when we stop and we say, what else could we be doing? Does this person have seizures coming from one area that could be resected? Should this person try the ketogenic diet? Should we move on to vagus nerve stimulation? What else could we be doing while we're still trying to find a fix? And so this is when we move on to a different treatment modality, because we should always be trying to make somebody seizure-free. About 15% of children with epilepsy have refractory seizures, and this is who I spend the majority of my time with. The goal of epilepsy surgery is seizure freedom. That's always the goal. But as many of you know, nothing in medicine is 100%. Our goal is to improve the quality of life of that child and that child's family, to improve functionality of that child, and to reduce the cognitive, behavioral, and emotional sequelae of ongoing seizures and from being on multiple medications, if that child's on multiple medications. Very importantly, people will refer to anti-seizure medicines as AEDs or anti-epileptic drugs. They're actually not anti-epileptic. They make it harder for the brain to have seizures, but they don't actually fix the epilepsy, unfortunately. I hope that somebody comes up with that treatment and puts it in a pill, but we don't have it yet. Also importantly is anti-seizure medications have side effects. All of them have side effects, and when you have to use 2 or 3 or sometimes even 4 medications together, invariably you have more side effects. And what's their effect on the developing brain? We actually don't know for many of them. Some we have some inkling, but this is the important thing that I think about every single day, and I think many of you do as well. The effects of seizures on the developing brain is nothing to be minimized either, and it's what we sort of weigh and balance as we're talking about switching medications or adding another medication. ongoing seizures and epileptiform discharges, when abundant, do have an effect on the developing brain. And the effects are seen more so in younger children, especially those who have intractable epilepsy from infancy. It changes the neurogenesis and synaptogenesis in the brain. It changes the connections of the neurons and the cells in the brain. And anti-seizure medications can cause side effects and affect long-term development. This is just one of a few studies that have attempted to identify the effects of seizures on the developing brain. What they did is they looked at and compared healthy brain development to the developing gray matter and white matter in children with epilepsy. And what it showed was a change. So in healthy children, they have a reduction in gray matter and expansion of the white matter connections between the cells. And you can see in this top chart how that changes in time. But in children with epilepsy, it showed that they actually had a reduction in the white matter expansion, or the change in the synapses or the connections between the different cells, as well as thinning of the gray matter. The gray matter is the cortex, or the overlaying part of the brain where seizures come from. And that was, and these connections were quite abnormal in these children. So the goals of epilepsy surgery are seizure freedom, and if not freedom, then a decrease in seizure burden, because this is all about improving the quality of life for children and their families, as well as improving developmental outcome. This is tricky though. As I always say, part of my job is to find the epilepsy, but then the other part is to make sure that we're not taking out a part of the brain that the child needs. We have some roadmaps of the brain. So here on the left, you'll see what's referred to as Brodmann's areas, or different areas that we think control different parts of your body, or your thinking, or your language, or your hearing. But to be honest, everyone's wired a little bit differently, especially children or patients who have had brain injuries when they were young, or even before they were born, they had abnormal development. Not everyone is wired the same, and we have to figure that out. So some of the testing that we do that we'll talk about is is to figure out where the epilepsy is coming from, and some of it is to figure out, is this coming from a part of the brain that we can remove safely? We discuss the outcome of patients and how they do post-surgically, referring to this as the Engel Classification. Class 1 is the goal for everyone, and this would be, the goal would be for somebody to be free from disabling seizures. Class 2, Class 3, Class 4, as you progress through the classes, those are worsened outcomes. Class 2 would be rare from disabling seizures, and sometimes that's the best that we can do. Class 3 would be when a child has worthwhile improvement, and Class 4 is where no one ever wants to be, which is where we've gone through this surgery, but for some reason this child or this patient had no worthwhile improvement in their epilepsy. So what goes into the evaluation for epilepsy surgery? This is so highly variable and dependent on each child. And this is done at level 4 epilepsy centers. And so because of this, on average, it takes a long time to be evaluated for epilepsy surgery for some people. And on average, you can just think this to yourself, how long do you think it would take to get to epilepsy surgery after developing intractable epilepsy? Believe it or not, on average, it's 20 years. So from developing epilepsy surgery to having epilepsy surgery, it's 20 years. The picture in here, this is what you get when you Google a 20-year-old person, believe it or not, when I put this together. So that's Justin Bieber. But not making light of a serious situation, which is it takes a really long time. So how is this decision made? Well, it's complex. The people who are the best surgical candidates are children with intractable epilepsy, but they have a lesion or a focal problem on their MRI, and everything fits with that. The seizures, based on what the person does, looks like it comes from that abnormal part of the brain. And if we're lucky, that's from a part of the brain that they don't need because it's on their non-dominant side or the side that the person's less reliant on. We do additional studies that you'll hear about, like a PET scan or something called a SPECT scan, and everything matches up. Everything lines up with that lesion that we see on the MRI. Those are the people who do the best, especially if it's in the temporal lobe. But it's super complex. And then what I always tell people, because everyone wants to know the next step, well, each step sort of tells you the next step. So I can't really tell you what we're going to do in 2 months until I get this next study done. At a minimum, everyone gets a very detailed history and examination. Then they have an EEG done that captures their seizures. So we look at their seizures both clinically and on EEG, and we analyze exactly and what they're doing to help us figure out where in the brain the seizures are coming from. But we can't just be dependent on that. We need additional imaging. At a minimum, everyone will get a high quality MRI scan. So that's a non-radiation way of looking at the brain to look for any little focal or subtle changes on the brain. Then from there, things are pretty individualized. Some people get functional MRIs to try to figure out the functional parts of the brain or the parts of the brain that can't be removed, trying to identify where language is or where motor function comes from the brain. Very commonly, people get PET scans, and I'll show you what that looks like. So that's a scan that shows a reduction in sugar metabolism in the part of the brain where seizures are coming from. Some centers offer something called a SPECT scan, which is when a child has an injection during a seizure right at the onset. A MEG scan is commonly used as well, and I'll talk about that. Everyone will also have a psychosocial evaluation by a social worker, a neuropsychologist, and speech and language pathology. Those are just at a minimum. WADA tests are sometimes done, much less so in children, and I'll talk about that. But importantly, no one person makes the decision to go to epilepsy surgery. Everything is compiled, all this data is compiled, and it's presented at a multidisciplinary epilepsy conference where multiple epileptologists, surgeons, radiologists, neuropsychologists, speech and language pathologists are all in the room, and all we do is discuss that patient, whether or not we have enough data, what additional testing we need from that, what we call phase 1 evaluation. Sometimes we're able to say, yep, we know where the seizures are coming from. It's not a part of the brain that the child needs. This is the right surgery for this child. Let's take it out. Let's go to resection. However, I would say probably just as commonly, we say, you know what, we need more data. We have to do phase 2 monitoring. Phase 2 monitoring we'll talk about is when we have to put electrodes in the brain to evaluate where the seizures are coming from. So believe it or not, when a child has an EEG on their head and we try to figure out where the seizures are coming from, it's really tricky. Doing an EEG on the scalp, you're actually kind of far away from the brain. So you need more testing than that typically. So here are 2 examples of commonly used tests. One's called a PET scan on the left, and the other one is on the right is a SPECT scan. The PET scan uses radiation, and it looks at the glucose metabolism of the brain. And in between seizures, you usually see hypometabolism or decreased metabolism between seizures. And so in this person, you're seeing a reduction here. This is probably the left, either frontal or parietal lobe, showing a reduction. It looks very different on the left here than on the right. A SPECT scan is a completely different study. What it involves is a person having a seizure in the hospital, and then a person is sitting at the bedside waiting for that seizure to start. They inject a radio tracer that goes to the part of the brain that's seizing or is active. And so you can see in this person, it looks like there's an area that has increased radio tracer in the right frontal lobe. You have to do actually 2 different scans, and you subtract those 2 scans. So one when the person's seizing, When they're not seizing, you subtract the two, and you get something called a syscom. A MEG scan is not done in every patient, but is very commonly done. And this is a completely different way at looking at where seizures are coming from. The child or adult is put into a scanner that there are many different forms of scanners, but this would be one example of a scanner. And what we're looking at is the very teeny tiny magnetic field made by all those spikes in the brain. So here's the spike on an EEG. You actually look at the magnetic field made by the spikes of electrical current. It's just one other example of testing that is done before surgery. So the majority of those tests I just showed were to identify where the seizures are coming from. Sometimes we have to do tests to ensure that we're not doing any harm or to predict if we could be doing harm. One example is a WADA test. This is less frequently done in children than in adults. And this helps predict any language deficits or more commonly any risk for amnesia or memory problems after a surgery, especially if you're going to take out part of the temporal lobe. And believe it or not, you put one side of the brain to sleep, you test the other side, and then you do the opposite. It's a pretty invasive test because a catheter has to be placed through the groin up to the vessels of the brain. So there is a low but real risk of things like stroke and dissection and vasospasm. The person has to be awake during this test, so a small child would not be able to go through this test. And I would say that this test in general has fallen out of favor with the introduction of functional MRI. But we commonly use it at the University of Michigan, especially in adult patients. When a child or patient needs phase 2 monitoring, meaning we don't have enough data, we need to better pinpoint where the seizures are coming from, grids are replaced or Stereo-EEG is used to better identify the seizures. So on the left here, you'll see what used to be used most commonly, which was a large grid put right on the surface of the brain. So this is what you're seeing here. This is gray matter, which is where seizures are coming from, and this grid is placed. So that this person has had a very large part of their skull removed, and then this grid is placed right directly on the top of the brain. Then the child or adult has seizures with this grid in place, and we try to figure out where the seizures are coming from. Over the last 5 to 15 years, this has fallen out of favor, and we do something that's much less invasive. Sounds kind of weird if you've never heard about it before, but it's something called Stereo-EEG, where little teeny tiny electrodes are placed into the brain. This allows more of a 3D representation of the brain and the seizures. As you can imagine, not all seizures come from out here on the surface of the brain. Some come from very, very deep inside. And that was something that we weren't able to see with these kind of larger grids. I would say if you talk to people after they have one of these procedures or the other, everyone would probably favor the Stereo-EEG because they feel so much better. It's not such a large surgery. Surgery, it's not as simple as it sounds. It's a complete joke because I am just so in awe of what our neurosurgeons are able to do. It's quite personalized for every patient. I keep saying that, but that's so true. Some children need mapping of their brain before brain is allowed to be removed, even if we know where the seizures are coming from, because we have to make sure that we're not removing a part of the brain that the child needs. Sometimes we have to do mapping in the operating room or out of the operating room. So before you go to surgery, make sure you ask about these things. Ask what will be involved, what are we going to be doing before, after. There's a lot of planning that goes into a surgery, hours and hours and hours, involving multiple members of this complex care team. Because it's so personalized and because there's so much testing that has to go in, for epilepsy surgery. Epilepsy surgery evaluation is completed typically over weeks to months. Sometimes we're able to do things because we have to more urgently, but it really takes weeks to months. Additionally, the team wants to make sure that the benefits of surgery are higher than any potential complications. It is brain surgery, right? Things can go wrong. And the testing done before surgery is designed to determine how helpful the surgery could be, determine what risks could apply, assist with weighing the benefit against any known risks, and to provide realistic expectations and not give false hope. Uncontrolled seizures increase the risk for harm, physical injury, accidental death, and something called SUDEP, if you haven't heard about it yet, which is sudden unexpected death in persons with epilepsy. So everything is about weighing the risks, the pros and cons of each step, whether or not to do surgery or not. So different surgical options. You'll hear about kind of standard resections, most commonly in the temporal lobe. We'll talk a little bit about corpus callosotomy, which we've touched on, hemispherectomies or hemispherotomies, laser ablation, and vagus nerve stimulation. That's not a resective surgery. That is a palliative surgery. So standard resections, most commonly you'll hear about temporal lobectomies. So this is about as straightforward as it comes when a person has seizures coming from their temporal lobe. If it's on their dominant hemisphere versus their non-dominant hemisphere, the surgeon simply takes out the anterior 2/3 of the temporal lobe, along with something called the amygdala and the hippocampus, which I think of as just sort of seizure centers. Sometimes that can be done. Sometimes somebody has to have a more tailored resection. So for example, the temporal lobe is involved in language. And if you're doing surgery on the left side, which in the vast majority of people is their dominant side, sometimes we tailor the resection to have it not involve any language center. Corpus callosotomy is a procedure done where the surgeon dissects and cuts apart the anterior 2/3 of the corpus callosum, which is this connection between the right hemisphere and the left hemisphere. And this is specifically used to stop atonic or drop seizures. Those are those seizures where somebody just all of a sudden drops and they fall and they hurt themselves, oftentimes having fractures. There's something that sounds quite dramatic, because it is, called a hemispherectomy or hemispherotomy. And this is when a child has a disconnection, typically, of one hemisphere that's causing problems. This happens, and this is needed and required in things like Rasmussen's encephalitis, where a child has a disease that affects and attacks just one hemisphere. I used to think about a hemispherectomy as this, which is removal of one half of the brain, but this is uncommonly done nowadays. Most commonly, we have just what we call disconnection of one hemisphere, because it was found that there are more complications when the entire hemisphere is removed. And believe it or not, you can just disconnect it and leave it in there. Laser ablation is a newer technology being used to target one very small specific area of the brain. If you know and are pretty confident about where the seizures are coming from, a cathode can be injected and the tissue is heated up, and just a very small area can be what we call ablated. And this is used sometimes. It's not as effective at controlling seizures in general as the resective surgeries, but for some people, this is a very good option. You may hear about something called a robot that is used to place those teeny tiny electrodes that we talked about that are used for Stereo-EEG. This helps with the math. The robot doesn't actually do all of the work. The surgeon still does the work, as you can see here, but it's to help with the math and the exact placement of the electrodes. And then the other newer cutting edge technology is when there is thermal ablation of a small area of the brain that needs to come out. And this avoids a larger craniotomy that is done typically to resect an area. This cathode is just placed, and then the tissue is heated up. Vagus nerve stimulation. This is what we call a palliative treatment for epilepsy. It does not make you seizure free, but it can greatly reduce the number of seizures that somebody has. And this is used when somebody is not a classical epilepsy surgery candidate, meaning we can't figure out where the seizures are coming from, or they're not coming from one area, or they're coming from one area, but that person really needs that one area of their brain. It's this device that's implanted under the chest. It's placed under general anesthesia by a neurosurgeon, and there's a wire that's connected to something called the vagus nerve in your neck, and little pulses of electricity are sent to the brain via the vagus nerve. This is adjusted every week or two initially, and over time, the child or adult can have less seizures. There are some complications, but they're not the same complications and risks that you get from medications. It doesn't make people sleepy or things like that. What you typically or commonly notice is a change in the voice, especially when it's going off. And it's going off all the time, but if a child or adult has a seizure, they can actually swipe a magnet right over this generator, and it can send extra pulses to help stop seizures. It is a device that's implanted into your chest, and so for that reason, there is a risk of something like a wound infection, but it's a very low risk and a very good option for some people. RNS, responsive neurostimulation, again, it's not FDA approved for anybody less than 18, but it is starting to be used sometimes when nothing else is an option for some people. It's a newer device, and it's something that's important to at least know about. But importantly, this one also does not make you seizure free. This would be when somebody has seizures coming from one area or maybe two areas of the brain, and you know where it is, but you can't resect it because that person needs that part of their brain. And believe it or not, if you give a very small electrical current to a seizure, it stops it. And so people still have to take medications when they have an RNS implanted. And they have to have this device looked at very frequently, initially quite frequently, and then every couple of months after that. But it can help reduce seizure burden significantly for some people. Epilepsy surgery outcomes. So the people, the kids, the adults who do the best long-term are people who have seizures coming from their temporal lobe, and their MRI shows a lesion where the seizures are coming from. These people in general have around a 70% chance of being seizure-free after epilepsy surgery. So that's not 100, but that's pretty high, and that's much higher than continuing to try medications. For everyone else, the results are just not as good. So if you're talking about somebody with frontal lobe epilepsy, or occipital lobe epilepsy, or parietal lobe epilepsy, chances of being seizure-free are lower, but they're not zero. So this is from the largest cohort of adult patient studies. So after epilepsy surgery, again, a lot of patients had epilepsy surgery. About 2/3 of them were seizure-free at 5-year follow-up. People who had seizures coming from the parietal lobe or occipital lobe who had epilepsy surgery, about 50%. So lower than 50% of those patients were seizure-free. And then the patients who had seizures coming from the frontal lobe, a little more than 1/4 of those patients were seizure-free. The data is better in kids. So in children who had temporal lobe seizures, close to 80% were seizure-free. Patients who had hemispherectomies, 67 to 75% were seizure-free at the 5-year follow-up. and patients who had extratemporal or multilobar, meaning multiple parts of their brain had to be removed, had a little bit greater than 50%. So all of these numbers are better than adult data, but none of them are 100%, which is very important. So an important thing to know that I always have to tell every person that I meet who are talking about epilepsy surgery is, I don't know how long you're going to be on epilepsy medications afterwards. The goal is always no seizures and no meds, but that's just not realistic for everyone, and I wish it was. The soonest we wean medications is 3 months post-operatively, but whether or not we wean medications is very dependent on the epileptologist who you're seeing. It's also very dependent on how confident the surgeon was and the team was that we resected the focus of the epilepsy. It also depends on some of the testing that was done and what that tissue looked like from the area that was resected. It's also dependent on how that person's doing on their medications. And importantly, I stress again, not all surgery is curative. Both resective surgery, not all resective surgery is curative, but also specifically the vagus nerve stimulator and the responsive neurostimulation, those are both palliative surgeries. So the hope is to use less medications, but those two treatments do not make people seizure free. So not just future directions, but now directions are, we don't focus just on the seizures, because having epilepsy is not just about having seizures, it's about the whole person. Sometimes we're better at treating the seizures than the whole person, but we're trying really hard to get better. And this is an area that I think we all think we could be doing better on. Also importantly, we need to improve the access to surgical care without delays, especially in the people who are very clear-cut epilepsy surgery candidates. But at the point where somebody becomes refractory, they've tried 2 anti-seizure medications and they're just still not seizure-free, that's when that discussion should at least come up. We're working in general, and researchers are working on improving brain mapping and something called electric corticography, which is identifying important parts of the brain, both for seizures and parts of the brain that we need. We're also all trying to work on improving how quickly we work somebody up for epilepsy surgery. We're working on more minimally invasive, when appropriate, seizure treatment modalities, like using the thermal ablation techniques when it is appropriate for somebody. But the focus should always be on the quality of life of that patient and the family. We're also working on building family and peer support groups for families as they go through this. So now I'm going to turn it over.
Thank you, Dr. McNamara, for that fantastic and comprehensive overview on pediatric epilepsy surgery. And at this time, I'm going to reintroduce everyone to our Epilepsy Foundation colleague, Megan Maddow, who is here with us tonight to share her family story and her son Anthony's epilepsy journey. Megan, thank you so much for being here and for sharing Anthony's journey with everyone listening in this evening. And thank you for sharing these beautiful photos of Anthony with everyone tonight. I would like to start by asking you, perhaps if you can just share with us a little bit about you and your family.
Sure. I would not be in this field of work if it weren't for Anthony's epilepsy. This is not where I saw my life going when I was going to college and growing up. I've been part of the team at the Epilepsy Foundation of Iowa for almost 2 years now. The work and the mission of the foundation to end epilepsy has definitely become my passion. I have 2 children, Anthony and Lacey. We adopted Lacey about 5 years ago. She's 10 years old now. And then Anthony, as you can see in all of the lovely pictures, he's my only biological child. He's 14 years old now. He was born 11 weeks premature due to eclampsia. He came into this world via emergency C-section after I had 3 seizures in less than 4 hours, and I had stopped breathing and suffered a stroke during this time. I do not have epilepsy, had never had a seizure before that, and have not had one since. It was all due to the pregnancy complications. But I felt then and now like it was a very strong foreshadowing for our life.
Wow. Thank you for sharing that very personal story. Can you share with us a little bit about Anthony's epilepsy journey?
Sure. Because he was so premature and because I had had such trauma with the eclampsia, he was born with a grade 3 and a grade 4 bleed, one on each side of his brain. He was in the hospital for 6 weeks because he was 11 weeks premature, and he was discharged when he finally got to 5 pounds. Not once in this time, with the traumatic brain injury that he had suffered, did anybody mention the possibility of seizures to me or my husband. Anthony wasn't developing normally. His motor skills were slow. He wasn't hitting the milestones that he was supposed to be, even when we adjusted it for his prematurity. And he had some major eye issues that was causing one eye to pull towards the middle. So we were kind of focused on that. And we were always at the doctor. There was one day a few weeks before his first birthday, I noticed that he kept twitching. His arms and his legs and his head would kind of pull forward and then quickly jerk. There was one time, there was a lot of times that he would do it once and then he would be just fine for a couple of seconds. And sometimes he'd do it again a few seconds later, and then sometimes he wouldn't. I felt like something was wrong. So I took him to the emergency room. The neurologist came into the room and explained to me that a baby has this thing called a startle reflex, and that's what I was seeing. I didn't argue because a neurologist is an expert at this stuff, or they're supposed to be an expert at this stuff. The doctor left the room and the nurse came back in. I was scared. I was a 20-year-old new mom, and I didn't want to make the brain doctors mad at me, but Anthony started jerking his arms and his legs and his head again. So I looked at the nurse and I said, I don't think this is a startle reflex. I've taken developmental classes in college. I don't think that's what this is. She ran and got the doctor to come back so that he could see what was happening, and that's when Anthony got a diagnosis of infantile spasms. We ended up staying under the care of that doctor for about 9.5 years, trying and failing medication after medication. No one told us there were other options. We didn't know that there was anything like an epilepsy center where there might be other treatments. No one told us that after failing those first few anti-seizure medications, that the likelihood the next one would work was very, very small. We just didn't know.
Yeah. So how did you respond when you learned that surgery was a possible treatment option for your child?
Well, we had switched to Anthony's current neurologist because we had moved across the state of Iowa for my new job. Apparently, there's something called an epileptologist, which we had never heard of. And the epileptologist, as Dr. McNamara told us, is a doctor who specializes in diagnosing and treating epilepsy. We happened to get an appointment with one just by chance. That doctor looked at everything in Anthony's records and decided to try one type of medication that didn't really work. When that didn't work, he was on board with us trying CBD. And when that didn't work, Anthony was evaluated as an inpatient, and the day he was ready to be discharged from his 7-day EEG, the doctor said the word surgery. I quickly said, nope, and we went home.
That's a hard word to hear for sure. What process did your family go through to accept the possibility of brain surgery as possibly being the right choice for your son?
Well, when we got home, I started researching epilepsy surgery, mostly so I could find every single alternative to surgery that I could. The ketogenic diet wasn't an option for Anthony because he was already struggling nutritionally. At that point, we had tried and failed 14 medications. The epileptologist was telling me surgery was Anthony's only possible treatment option left, and that it had a possibility of bringing Anthony seizure freedom. I was still unsure about surgery. I didn't know anything about epilepsy surgery. And then shortly after the conversation, Anthony had a seizure that just kept going. He went into status, and I gave him his rescue meds, which was pretty common for him, but they usually stopped that seizure. This time it didn't stop. I called EMS. They gave Anthony 4 more doses of different rescue medications before they were able to get the seizure to stop at the hospital 45 minutes later. Anthony turns blue during his seizures. I thought he was going to die. I emailed his doctor that night and said to make a consultation with the neurosurgeon. And after seeing all that, I was ready to consider surgery.
Well, I'm sorry our family had to go through that traumatic experience. That's very, very difficult, what you described. And when you got to that point, when you were ready to consider surgery, where did your family find support leading up to the surgery?
The first place that I spoke to was the Brain Injury Recovery Program. Back then it was called the Hemispherectomy Foundation. They had a lot of information on the type of surgery that was offered as Anthony's treatment, which was the hemispherectomy, so the disconnection of one side of his brain. They also referred me to my local Epilepsy Foundation. I called and got a hold of the Epilepsy Foundation of Iowa's executive director, who was a tremendous support, and got us in touch with local families for peer support as well. So the foundation was kind of our stepping stone to be able to accept that surgery was going to happen.
It's great that the foundation could be there to help support you. Anthony went on to have surgery, and what was that recovery process like for your family?
Well, it was not what I expected. I had read and done all the research I possibly could, and I was told to plan for him to be in the hospital for 2 to 3 weeks, and then he would move to an inpatient rehab for 2 to 3 months, depending on how much recovery he needed. We also assumed, based on his testing that he had done, that he wouldn't be able to speak, so we had to plan for assistive technology that might need to be implemented. I planned and planned for this surgery because that's what I do. He woke up after this 12-hour surgery in the ICU. He smiled at me, and then he said, "Mom, my head hurts. Can I have my tablet?" So he was ready to play his tablet after this 12-hour brain surgery, and he was his normal, silly self. And I thought they didn't do the surgery. I thought there was something that just didn't happen. I think day 3 and day 4 were the worst, with the post-op swelling in his face, and he then had this lack of impulse control. He was very combative at times, but at the same time, that got him to move his arms and his legs. He was in the ICU for 4 days, and then he moved to a regular pediatric neurology unit. He got down on the floor on day 8 and slowly and wobbly crawled across the hospital floor with me trying to make sure he wasn't going to bonk his head on anything. And crawling was his typical mobility prior to surgery. And he was doing this 8 days post-op of half of his brain being disconnected. And it was unbelievable. He was a little bit slower, but he was on pain meds. And he was doing so well that they ended up discharging him directly home on day 9. He did outpatient physical therapy and occupational therapy, but quickly got back to his new baseline, which wasn't really far off from his previous baseline. It was absolutely amazing.
Wow. Well, can you share how Anthony and your family are doing post-surgery now?
Yes, Anthony's doing great. The picture there on the bottom right is him on his last day of his 8th grade year, so just a couple months ago, in his Cubs jersey. He did not get seizure freedom like we had hoped from his hemispherectomy, but there were a lot of circumstances that went into this, and we didn't know 100% if he would, obviously, as Dr. McNamara said. So he had his surgery December of 2016, about 2.5 years ago. Once he was recovered from the surgery, we were still seeing those seizures. So in April of 2018, we added another med to his other 2 that he was already on. And he has now been seizure-free for 1 year and 3 months. This gave him seizure freedom from the first week that he started that medication. At first, it was difficult to really see any progress. The side effects from the medications were excessive sleepiness and aggressive behaviors, very aggressive behaviors. But after a few weeks on the medication, I started to see the old Anthony, the best parts of Anthony really start shining through. He wasn't seizing all the time, so his head didn't hurt anymore. With his headaches gone, he started eating and finally gaining weight. You can see how skinny he is in these pictures. He was able to pay attention at school for longer periods of time and started progressing with his IEP goals. And instead of worrying about where his trash cans were around the house, because he would get sick with every single seizure, it felt like, he now gets to worry about where his wiffle ball bat and his wiffle ball are. He really got to be a kid again. And it's the most wonderful part of his whole story, is to see him go from this horrible seizure, all of these seizures every single day, to it's been 1 year and 3 months. And it's not the first thing I think of when he yells for me now.
It's fantastic to hear that he's doing well. It's really great. And I'm sure a tremendous joy for you to see him progressing and developing and doing things that you'd like to see him able to do. What advice would you give other parents, Megan, when they're considering surgery?
Well, in our case, I wish we had known surgery was an option much sooner. He was 11 at the time of his surgery, and the plasticity of his brain would have been greater if the surgery had been done years prior. So hopefully he would have gotten more back from what he lost. My other advice is to listen to your gut and do your own research. Now, this makes a lot of doctors cringe when they hear a patient's done their own research. Don't just go out and believe everything you read online. Find the credible educational resources within the medical community. Every person's different, but research and information that gives you a better understanding is so helpful when you're considering any treatment, especially for your children. And another important thing to do is talk to other parents. You need to know the good and the bad, and you need to trust your gut.
It's great advice, Megan. And thank you again for sharing Anthony's journey, your experience, your insight. By sharing your family story, you shared vital information about finding the right care, exploring all options to help control seizures, and the importance of getting to an epilepsy center. Really appreciate your effort to help other families by being here with us tonight and through all the work that you do at the Epilepsy Foundation of Iowa.
Thank you.
At this time, I'd like to again also thank Dr. McNamara for leading tonight's learning. I would also like to share with you resources to help you to continue to learn about epilepsy and epilepsy surgery and to find support throughout your family's epilepsy journey. Certainly, speaking with your physician or nurse is always a good place to start. Keep in mind that referral to an epilepsy center may be necessary for you to be able to determine if your diagnosis is correct and what treatment options are best suited to help your child. You can also find up-to-date information and education online at epilepsy.com, and it can help you to stay up to date on advances in epilepsy and epilepsy surgery. You can also find resources and links to programs to help your family communicate with your child's school and providers. These programs can help to educate and inform your child's teachers, school administrators, school nurses, their classroom peers, and any and all school personnel that might be involved in their care during school hours or during after-school activities. For help guiding you to additional local, state, and federal resources, you can also call into the Epilepsy Foundation's 24/7 helpline for assistance. In addition to that, your local Epilepsy Foundation office can help to provide you with information, resources, and support education, advocacy, and programs geared towards families. It can also help to direct you to an epilepsy center close to your home, where you will find medical providers who specialize in the diagnosis and treatment of epilepsy. I would also like to share with you some information about our colleagues and collaborators in supporting families who are navigating the course of epilepsy surgery, the Brain Recovery Project, and the Hemispherectomy Foundation. The Brain Recovery Project's mission is to help children to reach their full potential after brain surgery to stop seizures. And they also offer help in a variety of ways, and some examples are through their Dreams for Danny Surgical Evaluation Travel Scholarship for families seeking pediatric epilepsy surgery evaluations more than 50 miles from home, which often people have to travel to get to an epilepsy center. Through special education advocacy, they offer 20 hours of free advocate assistance for parents who are navigating the IEP process after epilepsy surgery. They also provide school training so that the educational team of the child understands functional implications of epilepsy surgery and how they might affect a child at school. And online, they also have other resources and learning opportunities you can look at. I would also like to share that this incredible organization strives to initiate the new research through their patient registry. Through the registry, they help researchers focus their efforts on the functional implications of various epilepsy surgeries, and you can participate in their registry through the link listed here, or by visiting their website at www.brainrecoveryproject.org. The Epilepsy Foundation is thrilled to have the Brain Recovery Project as our partner in the Foundation's Epilepsy Learning Healthcare System initiative. I also wanted to take this opportunity to mention the Hemispherectomy Foundation, which is dedicated to hemispherectomy education, awareness, fundraising, and research of the medical conditions that cause intractable epilepsy that lead to surgery and the surgery itself. You can learn more about their support for families through the link listed here. I'd like to take this opportunity to again thank our guest speakers, Dr. Nancy McNamara and Megan Nadal, and I would also like to thank everyone for their attention, for tuning in for tonight's webinar learning opportunity.